Are we having a problem, Bruce?
I'm ready to go, so I might welcome everyone. I just was waiting for Innocent to come on. Are you there, Innocent?
Yeah, I am there, but our presenter is just setting up things, so I think we would request for about 5 to 10 minutes to begin. I'm just in touch with him.
All right, excellent. Thanks. What I might do is just welcome everyone and do a bit of an introduction, and then hand over to Innocent to both introduce our guests and to talk about the conference. So thank you all for joining us tonight. I think this is if you like, a forgotten subject in lots of parts of the world, the whole issue of Indigenous rural health, and obviously it happens in every country in the world, and is just as important in Africa as it is elsewhere. These webinars are part of the 18th World Rural Health Conference. I'm very proud that Innocent and Jane and Joy have been able to pull this together from lockdown in Uganda. They're in collaboration with WHO, and I'd like to just, if I can bring up the slide, just to remind everyone of the schedule for these, or the arrangements for these. We'll be putting the schedule up in the next few days after some further discussions with our colleagues in Uganda for the exact dates. The seminars, as I said, in association with the WHO webinar series, and the conference is focusing very much on what's happening in Africa, and then the WHO webinars are focusing on how we can take that right around the world and look at the world perspectives. So the last one was on rural proofing. This one's on social participation, community engagement approaches for health in Indigenous populations, and particularly focusing on Indigenous health. The next one is around policies to develop, attract, recruit and retain health workers in rural and remote areas, and promote particularly gender equality for rural women. And we'll be having another seminar, and I'll talk a bit about that at the end. Another seminar about particularly rural women in Africa. Then the third or the fourth one will be is innovations in equity-orientated healthcare delivery in rural and remote areas in lower and middle income countries. Then we actually focus a bit more on the agricultural sector, which is very big, obviously, for many of us in rural areas, and that alignment with the agricultural sector. We're proud with WHO, we're actually working with FAO and others in those areas. Next is health information systems. And I know when I went to India for the World Rural Health Conference, I was really quite gratified to see how some of the technology is assisting in rural areas. And then finally come back to rural women and addressing inequalities in health service coverage. So those will spread out over the next few months into February. And we're obviously looking at this leading up into the 2022 conference, which we hope will be at least in part face-to-face in Ireland. So I hope that gives you a bit of a flavour of what we're doing. There'll be, as I said, before each of the WHO sessions, an 18th World Rural Health Conference session, and we've been encouraging you, if you've got interest in those areas that I've just brought up, to be talking to Innocent. We'll try and get a bit more formal process of people applying for those and being part of the the conference panel, and then obviously being able to contribute up into the WHO panel as well. So, Vince, Innocent, are you ready now to take over and do an introduction?
Thank you very much, Bruce. First of all, I would really like to thank you very much for putting this together and making everything happen. Of course, this topic is quite important. Many people don't actually think about indigenous populations in Africa. And it has been quite neglected because we know indigenous populations have their own unique issues, which we really thought we should bring to the table and also to the consciousness of all of us, so that we really start thinking about them and see how well we can include that as we try to achieve the universal health coverage. So today we shall have presentations from our panel of experts, but I think before I introduce them and invite them to start on their discussion and their contributions, I think allow me to invite our president, the president of the Association of the Family Physicians of Uganda, to welcome you, because you know the host is the Association of the Family Physicians of Uganda, and I think it is in order that the president welcomes you to this event. Then we proceed. Dr. Jane.
Hello?
Yes, we can hear you.
The Association of Family Physicians of Uganda is very happy to have you participate in this webinar with us, and we appreciate. We thank you for your time, and we hope that we'll have a fruitful discussion, especially with these special groups of persons. We have people from Botswana, India, Nigeria, and our own in Uganda. So we hope that even when we start the discussions, we shall have a lot to share, and we hope that this will go a long way in impacting the way we do our work in our environments in the different countries. Thank you very much. You're welcome.
Thank you very much, Dr. Jane. I see Dr. Birungi is with us now, so we should be good to go. By way of housekeeping, we are going to have a presentation from Dr. Birungi, whom I will give you the details just in a minute. Dr. Birungi will be talking about healthcare for indigenous populations in Uganda, and I think I am right if I say that where Dr. Birungi works, which is the Bwindi Community Hospital, I think it may be the only hospital in Uganda that was specifically set up to cater for indigenous populations. I really don't know any other. And I think he will be giving us the details, but there is an indigenous population in that area, which was actually the original inhabitants of the place that is now gazetted for gorilla tracking. So Dr. Birungi is the executive director of that Bwindi Community Hospital, which is a private not-for-profit organization, and it offers both healthcare and training, but specifically, it was founded with a special mission to provide the care for the indigenous Batwa people who previously inhabited the Bwindi impenetrable forest before it was gazetted as a sanctuary for endangered mountain gorillas. So it actually began as an open air clinic in 2004, but has managed to grow into a full-fledged hospital, and with also a training department, which is trained as nurses, midwives, and clinic officers. And I think this is important that these people are trained hands-on on how to care for indigenous populations. Dr. Birungi is a public health specialist with experience in strategic management, And he also holds a diploma in health systems management from Mogadi International Management Institute, Israel, and also holds a Master's of Science in the Public Health from the University of London, the UK, and the Bachelor of Medicine and the Bachelor of Surgery from Makerere University in Kampala. He's currently a doctoral candidate in business administration at Paris School of Business in France and the Guide International Management Institute, Israel. And his focus of study is on corporate strategy for private non-profit tertiary healthcare and health training. And Dr. Birungi is a Paul Harris Fellow of Rotary International, and he now is currently the president-elect of the Rotary Club of Chihihi, which is the local town of where he stays and where he works. And he has also authored and co-authored several scientific publications. So he will be speaking with us today about the development and the provision of health services for indigenous populations in Uganda, and specifically focusing on the opportunities, the challenges and lessons learned from Mubindi Community Hospital, where he has been serving in various roles. And after his presentation, we shall also invite our panel, our panelists, who are people from really Africa mainly. We have somebody who is from Nigeria representing the Western Africa. We have one from Tanzania, and then one from Botswana representing the Southern Africa. And I think we know very well that in the Kalahari Desert, we have, I think, indigenous population is there, so we shall hear from them. And then another panelist from Malaysia, who will also give us insights on what is happening on the Asian continent. So I think without wasting much time, allow me to invite Dr. Birungi to make his presentation, and maybe also add what I may have missed in introducing him. So Dr. Birungi, you are very welcome.
Thank you so much, Dr. Innocent, and all the other people in attendance. My apologies for coming somehow late, but I think we are good to go. Let me share my screen and we start.
But are you able to share? Oh, Bruce has to make you a co-host.
I should be able to share, but I'm just still looking.
Yeah.
File, but I can still forward it. There would be no problem with that. Let me just sorry for that delay. Sorry, no, I am not.
I think you can send. Oh,
That's sharing now.
So are you able to see the
We
screen?
can see it perfectly. Thank
Yes,
you.
we're able to see. So you can go into PowerPoint in the slide show. So.
Yeah, okay. So is that okay now?
Yes.
All right. So thank you so much. As I've been introduced, I'm Dr. Birungi, and I head the Bwindi Community Hospital. And it's a privilege sharing with you our experience as a Bwindi Community Hospital, dealing with the Batwa Pygmies, who are considered one of the indigenous populations in Uganda, and initial inhabitants of Bwindi Impenetrable Forest, which is now a national park. So our presentation today, we talk about we'll go through the background, the scope of our intervention, challenges, opportunities, and lessons learned. So the indigenous people in Uganda include the Batwa, the Ik, the Basongora, among others. Although the government does not recognize them as indigenous people, but rather like any other tribe. And around 1991, these forest nomads in the Bwindi Impenetrable Forest were removed to conserve mountain gorillas, which were considered an endangered species. And they were hunter-gatherers. Now, after getting out of the forest, they were left homeless and in extreme poverty and landless, I should say, and with very few options to improve their lives. So people who had for all this time lived as hunter-gatherers, they had little knowledge about farming or even construction of homes. And so living in the predominant tribal groups exposed them to all sorts of exploitation, but also they were starving and their existence threatened by fatal diseases, and most of them actually preventable diseases. So around 2000, Dr. Scott Kellerman, who was a missionary from the US, to be specific, from California, came and was working with the Church of Uganda and the Diocese of Chinchizi, which is in southwestern Uganda. He did a survey and found that 38% of the Batwa children would die before the age of 5 years, and life expectancy was about 28 years. But even then, I think for the rest of the Ugandan population, life expectancy was around 56 years. So probably this was about half of the general population. And as I've pointed out earlier, most causes of death were from preventable conditions as malaria, diarrhea, and other diseases that are associated with the sanitation and hygiene. So around 2001, Dr. Scott began an open air clinic, working alongside local nurses and community members. But it turned out that the general population was not any better, because much as the Batwa were worse, but they also didn't have access to quality healthcare services. And so the community members mobilized and thought they would acquire land on which a health facility would be built. And since then, 2003, when the first structure was put up as an outpatient department, the hospital has since grown to offer specialized services in a number of fields, including surgery, child health, mental health, among others. And we also have started a health training agenda for nurses and midwives, as we had in the introduction. We also train clinic officers. These graduate with a diploma in clinical medicine and community health. So that's just an illustration. The resolution might not be good, but those are the early beginnings. You can see this was under efficacy tree. Mostly these people would be suffering from malaria, and by then intravenous quinine was the drug being used. So there is Dr. Scott there, and the team I was working with. Here, probably Dr. Innocent, you should be able to recognize this was the first Ugandan doctor to join in. Dr. Ricky Biaruhanga now is an ENT surgeon. So he had joined the team also working to provide health care to the Batwa, working in an open air clinic. So what do we do? What was the scope of intervention for Batwa health? Effort was made as much as it could permit to address determinants of health in general. And as you will notice, most of these are not necessarily in the mainstream healthcare as we know it from many perspectives, but these included land acquisition for building homes and growing food, because these people were homeless, were landless, just living at the fringes of Bwindi Impenetrable National Park. And then the other was to accord them education in various schools within the district. And some actually have studied up tertiary institution level, graduating with degrees and diplomas. And then access to quality healthcare was one of them. And here we have ensured that all the Batwa have a health insurance plan with the hospital, such that they are able to access health care irrespective of their income or geographic means. And then there was aspect of income generating activities where Batwa were given livestock, pigs, chicken to start with, but again, this is limited by the small portions of land they live on. Then skilling the Batwa in tailoring, bricklaying, and carpentry. Also engaging them in participation of development of healthcare interventions. In Uganda here, we have different levels of healthcare. The very first one is that of the community, which is comprised of the village health teams, where village health volunteers are trained in the basics of disease prevention and identification of some of the simple ailments, and each person is in charge of about 25 households. So in this case, we trained those specifically living in the Batwa settlements, because there are about 8 Batwa settlements on the Kanungu side of the forest. There are others who are on the side bordering with the Democratic Republic of Congo and in another district in the southern part of the forest. So these ones, we ensured that at least in every settlement, there are those who are trained to boost health awareness and health demand. And then also, we developed a digital reporting system for the entire community, but also ensured that the Batwa are also included in this, whereby community members can report directly to the hospital on issues to do with the vital statistics, death, birth, but also disease surveillance, including patient satisfaction, using a community scorecard to rate the services of the facility and what can be done for them. And then we also engage them in community outreach services, provision of clean and safe water. And then we have noted that over the past 16 years of operation, malaria among the Batwa has reduced by 90%. And so is the prevalence of diarrheal diseases. Now all Batwa women deliver in the hospital because they have an insurance plan and they can call for an ambulance, courtesy of the VHT, the village health promoter who is trained within each settlement, is supposed to call in the event that they require transportation to the facility. And then 95% of the Batwa have got houses and land where they can grow crops. Of course, the land is becoming inadequate with time because their population is somehow growing and land is not expanding, and they have little means to acquire new property. Over 250 Batwa children have been supported in schools, including tertiary education. But despite these, health inequalities still exist, as we saw in a survey that we did in 2018. I'm not sure whether you would be able to read these. They are really tiny, but I will share this PowerPoint presentation after by email. I should have done this earlier. Sorry about that. But then we found that the household size for the Batwa and the general population now is about the same. For the Batwa, it's about 4.9. The general population in the area 4.7, but nationally, that's about 4.7. That is the average household size in Uganda. So they do not differ so much from the rest now. Then when we come to health insurance, which is a means of ensuring that the population accesses quality health care irrespective of what they earn, we found Batwa population, about 73% is insured, compared 32% of the general population. And this is because of collaboration with another organization that we work with, the Batwa Development Program, that ensures that every Mutwa is insured. And now this is well above the national statistics, because in Uganda now, less than 5% of the population has an insurance plan. So 73% for the Batwa, 32% for the general population in our catchment area. Sorry, 70% for the Batwa and 38% in the catchment area. Then 5.1 as a coverage of insurance in the rest of the country altogether. Cell phone ownership is still low, as you can see, 19% of the Batwa own a phone. We are just looking at households, at least having one handset in each household. So the Batwa, 19% of the households have a phone, at least one phone. And the general population in the catchment area is at 57%, while nationally, 73% of the households have at least one handset. Radio ownership, 36% of the Batwa households, compared to 61. And then when we go to sanitation, we find that 43% of the Batwa households had access to safe and clean water, compared to 79% of the general population. And also we looked at hand washing facilities with soap, very low at 1.8% compared to 17. But then of importance to note is the alcohol use among the Batwa, standing at 32% compared to 10% of the general population. And for the Kigezi region, that is southwestern Uganda, where we belong, the national statistics of alcohol use is about 15%, 15.6%. So you see, the Batwa alcohol use among the Batwa is about twice as much as any other person in the region. So what are the challenges? The challenges we have identified, one is financial sustainability of some of the interventions. For example, their health insurance cover is made by some other NGO. And so in the event that they are not able to continue, then that would leave them exposed. The Batwa indigenous people are also exploited, not only by the local communities, but also some NGOs, briefcase NGOs who come purporting to help the Batwa, but then you find in the end, actually, they are using them to get money for their own benefit and do little or nothing for the Batwa. Food insecurity is still a problem because of the small parcels of land they have, and some of them actually not that fertile to support growth of enough crops for food production. And also the other challenge is they are comparatively very low purchase power for acquisition of new property as their population grows. And also the battle having lower capacity for climate change adaptation. We have seen even in this region over time, for example, water sources are dwindling. Say in the last 10 years, you find that perhaps about 30% of the surface water has dried up. And you find the battle have got limited capacity, for example, to engage in crop irrigation or even water harvesting and storage. So some of these global challenges, but which have got much more impact in disproportionate measures to these indigenous people. Then feasibility of livestock households as an adaptation option for the batwa is threatened by small pieces of land. Again, I find even if, for instance, one wanted to give them, say, cows or cattle to look after, or even goats, they might not have, enough land to look after these animals. And also due to high poverty levels, some intervention gains can easily be undone. An example here being the free insecticide-treated mosquito nets that we distribute from time to time. You find the attrition of those nets in these communities quite high, that within maybe 18 months, most households have sold their nets in exchange for money because they have got other needs that have to be met. So now that can actually undo any gains in as far as malaria control is concerned. What opportunities do we have? There are various platforms that now can be used to amplify the plight of indigenous peoples and their health. And I think this has been enabled further by advance in technologies, use of social media, and now it is easy to connect. And I think for anyone advocating for any improvements in health of indigenous peoples, the platforms are there. Then also opportunity for research into ways of how these indigenous people can be helped, how their health can be improved. It's not uncommon to find a number of interventions designed, but then at the end of the day, you find they have had very little impact. So probably through more inquiries, we would get to know what works. And because these indigenous people are everywhere, everyone knows they face certain challenges, compounded by so many things, but also getting to know what exactly works for them, I think is an opportunity that could be looked into. And then innovation, which also follows, closely research, because there has to be innovation, for example, in a kind of technology that could be used, say, even in farming, where they can have, high yields, innovation in a number of, interventions that would have high impact. So the other opportunity would be engagement of charities and civil society groups. And again, this can be facilitated by how much now the world is well connected, highlighting, the needs of these people and how they can be helped. Then engagement of governments, because I think all these civil society groups, charities, and researchers, all these can work together to highlight the plight of indigenous people and their health status and how they can be helped. So what have we learned in our experience is that tackling indigenous people's health really requires a multifaceted approach. And for us here, we have been lucky that our major financing has been coming from a foundation that was started by Dr. Scott. And so this foundation has got two arms, one to deal with healthcare as a Bwindi Community Hospital and health training, but also Batwa development program that deals with land acquisition, education, home building, and so on. But even then, over the last 15 years, we have still seen that health inequalities still do exist. So the other lesson is engagement of local community for sustainable integration or reintegration in some cases where actually people were driven away from their initial habitats. So this is a key because you find in some areas people are hesitant even to offer job opportunities to indigenous people because of their low levels of education or their skills wanting in a number of areas that they might not compete with the rest. But if the communities are engaged and they feel and know that this is something they ought to know, I'm sure they can also find a niche where they can fit and they earn livelihood and improve their health status. Then there has to be preferential treatment of indigenous people to improve healthcare access and utilization. And in our case, this is what I've already mentioned, whereby there is insurance targeting all these Batwa to ensure that each and everyone has got an insurance plan and can access health services, because otherwise they won't be able to access health care. And the other, for instance, has been deliberate taking of outreaches, health outreaches close to these settlements and within actually the settlements, because the service might be free, but if the distance between the point of care and maybe the village where some of these people live is considerable, then they might not even be able to reach. So those are some of the considerations that have to be looked into and a deliberate action, affirmative action taken. And then the other is direct involvement of these indigenous people in planning healthcare interventions, such that these interventions are acceptable and sustainable. In our case, including taking some of these children, away for education. Some of them would be skeptical. They would want to stay with their young ones in those settlement camps, but also interventions that we have looked at as keeping insecticide-treated mosquito nets instead of selling them out. So when these people are involved in planning and implementation, then some of these services are more acceptable. And that's why now the Batwa village health promoters engage in reporting the vital statistics in their settlements. So here we see this is actually this is a typical village of these people, as you can see. Tippet taps or foot operated hand washing facilities during this COVID pandemic, and supplying them with soap and so on to encourage hand washing in all public places in their settlement. Here we see children being vaccinated to one of the outreaches, and in the background there you can see is a hut, you know, typical of most of their houses. But perhaps this would be the only way of getting these children vaccinated other than coming to the health facility. And this is one of the settlements. Here you can see fetching water from actually very contaminated. You are fetching water where they are again stepping, but then this was eventually protected such that the water is safe and clean for use. And then here from under the tree, this is now the face of Windy Community Hospital and the nurses training school that I've mentioned before to improve health care access and health training to rural communities. So thank you so much. Once again, I apologize for delay and some hiccup at the start, but here we are. I would be glad to take any questions or any clarifications. Thank you.
Yeah, thank you very much, Dr. Birungi. We understand why you came in late. It is, I think what probably you didn't mention is how many doctors you had, how many nurses taking care of those large numbers of people. But of course, I am sure, I know you are really not many, and I understand why you came in late. But thank you very much for this wonderful presentation. And there are really a lot of things we learn from. Many people may have never, the people with us here, may never have heard of the Batwa people, that they were actually fruit gatherers and hunters in the windy forest. And the government just took them away. I mean, it took their land away and their livelihood, but without acknowledging that they required to really have, they required resettlement with all of the social services required. Maybe I only got one question, which was actually sent in the chat. And Vincent is asking, when are the Batwa people going to be able to take care of themselves? I think that is the issue of sustainability you kept hinting on. But I think it would really do him justice if we can answer, if there is any hope of them being able to take care of themselves in the near future.
Yeah, I think that's already underway. As I have mentioned, we have engaged in their training. So I should say, for example, now in one of the settlements, one of the health workers now offering care there is a Mutwa who has graduated from our nurses training school. And there are also other Batwa who have trained up to, who have even graduated. Actually, one has master's degree in business administration and is now working with the Batwa development program. So I think steadily and surely they are getting there, that they will be taking charge of themselves with time, but it will certainly take maybe a generation.
Mm-hmm. I don't know, Dr. Birungi, whether you can be with us for the next panel discussion, but I think it would be important also to learn from other colleagues. Is it possible for you to hang around a bit?
Yes, I will try, certainly, I will.
Okay, thank you. So I think let's move on. Then we can also, okay. But I think these are, okay, we have two other important questions which I think we need to look to, because for example, Jude is asking, what is the population size of the Batwa? Do you know the estimated total number?
Yes.
And in terms of social services, how many health units are in their catchment area, and maybe how many schools? It would be important to know so that there is a holistic understanding of this unique community.
Yeah, thank you so much. The total population of the Batwa in Uganda, according to the 2014 population census, is about 6,000. But for our catchment area here, where the hospital is located, we are serving 1,113 Batwa. So they are just over 1,000. And to talk about the health facilities, Windy Community Hospital is a main facility, but then we have specifically put satellite clinics in 2 of the most remote Batwa settlements. As I mentioned, there are about 10 Batwa settlements. So we have put one settlement across the neck of wind impenetrable forest in a place called Chitahurira, and another one in Byumba to improve healthcare access. So I should say, overall, the facilities that are there specifically to serve the Batwa are 3, and then there are other 4 government facilities, but all of them are at a lower level than a hospital. They are at the health center 3 if the participants are used to that kind of nomenclature.
Okay, thank you very much. I think we, in the interest of time, let's move to our panelists. Maybe you can stop sharing, then you will.
Okay.
So we shall start with Vincent, our who is from Botswana, the southern part of Africa, to get some insights on the situation, on the care of indigenous populations there, and then after individual discussions, then we shall just come to a wrap up. Vincent Setare, are you on?
Yes, I'm on, if you can hear me.
Yeah, we can hear you well. Go on, please. Thank you.
Okay, thank you. Thanks a lot, Mwinji Mutahunga, for your very enlightening presentation. And yeah, I'm very impressed by the fact that the indigenous people of Uganda, it's like you're describing the indigenous people of our country, Botswana, because they have the same problems. In Botswana, we have what we call the Basarwa, and these are people who all over the world are called the Bushmen. But they are not the only indigenous people. There are quite a number living in remote areas in different parts of the country. As you know, Botswana is a very big country. And what these people really, the challenges that they face in Botswana is poverty, alcohol abuse, drug abuse, tobacco abuse, and they suffer from the common preventable diseases. Their diets are also not very nutritious. They depend mostly on just carbohydrate diet and a little bit of protein. And of course, they've been hunter-gatherers for the rest of their lives, and they are still near the bush, and they eat fruits when they are available, and these are in the summer months, but the rest of the year, they don't have much of fruits, and they don't have money to buy fruits from the shops. And just like in Uganda, they are very exploited. They look after our cattle, they look after our homes, and they look after our fields. We use them for cultivating our fields, and we pay them either by giving them food to eat or just very little money. So, and another thing that is a challenge for these people in Botswana is the fact that traditionally they have childhood marriages. You find an old man marrying a very young girl, and there is no marriage whatsoever. It's just cohabiting. And so you have a lot of intergenerational marriages. So this is a challenge in a country where you are trying to foster women's rights, you're trying to prevent intimate partner violence, and so on and so forth. And their access to health is very, very problematic because they are living out there in the bush, either looking after cattle, or they are out there in the bush during the time when we cultivate crops. They are out there in the bush and they only come to the main villages where the clinics are, maybe over weekends or maybe during month ends only. And so their access to health is limited in that fashion. And another limiting factor to their access to health is the language. The people who take care of the doctors and nurses who man the clinics and health centers don't speak their language. And those who speak their language, they only speak it superficially. And those who, and these people, the indigenous people, when they speak the official language of Botswana, some of them, they only speak it, they understand it not very well, and they don't speak it well either. Fortunately, the government has tried to assimilate these people into the mainstream culture of the country. There are pros and cons to this, because they are being encouraged to come out of the bush and stay in settlements. And when they stay in settlements, alcohol abuse and all other things, violence just flares up. I think I've heard or read about the same phenomenon in Australia. So, and when they come and settle in the settlements, they lose their culture, they lose their bearings. But the government has got many schemes. They give them cattle, they give them food, and there's a lot of assistance that is given to these people over and above the assistance that is given to the mainstream citizens of the country. There used to be mobile clinics, but I don't see much of them. I think the government is now relying more on the clinics that are in the main villages to service everybody. Yeah, so I think, having said that, I think I will give room for other people, but what I've taken home from Dr. Mutahunga is that when you talked about the Batwa in Uganda, you were completely talking about the indigenous people of Botswana. They face the same challenges, problems. Yeah, thank you.
Yeah, thank you very much, Dr. Vincent, for that important insight. For the interest of some of our participants who may not be familiar with Vincent, Vincent is a family physician and the head of the family medicine department at the University of Botswana, which is one of the states in Southern Africa. And he's always very passionate about the health of disadvantaged population. Thank you very much, Vincent, for sparing time and be part of the discussion. Let's now move up to West Africa. I don't know, Tijani Osen, I think he should be on. Dr. Tijani, you are welcome to give us your insights from the western part of Africa. Thank you.
Thank you very much, Dr. Innocent. And I want to thank Dr. Birungi and Dr. Vincent for their insight. The story in Nigeria is not too different from that of Botswana and Uganda. You know, Nigeria has a very large population, over 200 million, and with over 300 tribes, most of them indigenous, from the Hausa Fulani to the Kanuri to the Yoruba, Igbo, down to the Benin, Edo State, where I work. And they all have their pockets of indigenous population who do have their peculiarities, but they all have similar situations. For example, there is this community in my locality where they are predominantly farmers, specifically rice farmers, but the problem is they are cut off from others, and healthcare services to them is abysmal. There's poor education, poor social infrastructures, and then no health facilities. The few health facilities that are there, the doctors are hardly on ground. Problems of the people by establishing primary healthcare centers across the country, mainly to attend to the needs of these people. These health centers, among other things, provide maternal and child care services, including immunizations and treatment of basic common infectious diseases. But it's hardly enough. The problem is, like I've said earlier, you hardly find a doctor in these health centers. Sometimes in a whole local government, the doctors manning these indigenous communities are just one or two for the whole local government. So in these health posts that are supposed to serve these communities, you mainly have nurses or community health workers. Yes, they're doing their best, but there's an extent to which they can go. Challenges is a big problem because there are hardly good schools for them. Again, government has ensured that there's a primary school serving these communities, but most of the time it ends there. After primary education, to go to secondary school, they have to leave to the nearest town. Some of them have to trek kilometers to get access to secondary education. And then that in turn translates into poor social amenities. Some will have to use canoes or walk through bad flooded roads to access the nearest town in order to get services. Now, how do we serve these people to improve services to them? Like I've said, government have done a lot and continue to do a lot in ensuring that services get to these people. The private sector have also come in. In most of these rural communities where you have this indigenous population, it is commonplace to have a private health facility there. So you could have this doctor who works in the town, but has a facility in the rural community serving the indigenous people. He comes at specific times so they know when to see him. Also, those health centers that are being manned by the nurses and the community health workers, because they have been doing this thing over time, some of them are very skilled. They know when to refer. They know what they can manage. But again, even when they have to refer, ambulance service is a big problem because most of these communities are not accessible. So getting them across to towns is another very big challenge, which they can sometimes overcome using bikes or even canoe for the riverine areas. But by and large, the government is continuing to ensure that these communities are served, while private initiatives are also joining hands to boost the health needs of this community. And of course, with the private hospitals come private schools, which though not as much as would have expected in terms of standards, but bridge the gap. But the major problem now with all this initiative is the brain drain that is currently affecting the country. Doctors, nurses are leaving the country in droves for greener pastures. So we hope that the government will do something to stop the brain drain, which would just be improving the condition of health workers in the country so that the doctors and nurses would stay and better serve the population. Improving facilities to these rural areas will further stem the rural-urban drift that we're currently experiencing, and then we'll have better services to the community. Once again, thank you very much, Dr. Burungi, for your presentation. Thank you.
Yeah, thank you very much, Dr. Tijani. And I think it is becoming clearer that these populations are quite significant on the African continent, and you must really start seriously thinking about them. I don't know whether Musuya Mariselina is online, but Mariselina, are you online? So I think she went off. So let's cross over to the Asian continent, and I would like to call upon Dr. Prim to, I don't know whether I'm pronouncing the name very well, to actually give us insights from the Asian continent.
Greetings from me. Am I audible, sir?
Yes, please.
My apologies, my camera is having problems. I hope you can have some good communication through this audio. First of all, thank you for the opportunity. And I have learned a lot from all the previous speakers, and it's a beautiful experience for me in Asia to learn about Africa. Sir Bruce and Sir Mr. Innocent and all the panelists, greetings from Malaysia. We call it truly Asia. Though very briefly and quickly, I talk about indigenous healthcare and socioeconomic status in Asia, ASEAN, where I am involved in the international non-government organization. First of all, they gave me an award in Bhutan. I want to start with a very happy note that why this country is the happiest country in the world. I just take notice on their king, wonderful king, and their prime minister is a doctor who sees patients every day free. Tell me how many prime ministers in the world do that. Very impressive, where they have this global happiness index. And imagine the curb tourism, so the indigenous population is saved. And imagine they do not figure very high in the money ladder, as we all know. Now, coming back to Malaysia, where I am, we have this very sustainable, beautiful program for this indigenous population who are hilly and tribal and far-fetched and marginalized and poor. And I'm in the COVID-19 task force. And what I am observing is this vaccine hesitancy. So a lot of awareness campaigns have to take place, a lot of political will, a lot of healthcare projects normally are in a very innocent stage, but they have to be moved up so that the real people get it. Easy for the urban population, but very difficult for the rural population. Just like not only in Africa, in Asia, in Asia, we have the same problems. I have been to the poorest ASEAN country, Laos, a place called Pakse, so difficult to go, where the camp was held without a roof. So you can imagine indigenous populations suffer a lot. They are poor, marginalized, they have a lot of addictions, smoking and tobacco chewing and alcohol intake and drugs, and that's due to diseases of neglected tropical diseases and communicable and non-communicable, and you just name them. And now with the pandemic, they are really into the deep. Now talking about India, where I spent a lot of time, the scheduled tribes and the scheduled groups of people as labeled by the Indian government, they need extra care. May I here, with great pleasure, make this a more flavorable presentation, though without a camera, that the recent silver medal, probably the only one won in the Tokyo 2020 Olympics, is by a girl from the northeastern part, and she used to carry forest wood on her head at the age of 12. And when the coach found out, why don't you do weightlifting? So indigenous people can even win Olympic medals. Now, have a look again. All over the world, there is a lot of talent. Yes, we will bark on the facts that they are the marginalized, they are poor, they're uneducated, their healthcare is poor, and we should be having a lot of special health cares like we have in Malaysia, where the teams go to them. They are also coming out. They're humans like you and me, and it is time that there's a lot of political will. There's a lot of these multinational companies, the NGOs, the stakeholders, the governments, a lot of foreign aid, a lot of teaching taking place, which I'm also a part of, which really makes me very happy that I am useful, at least in this lifetime, to people who need us the most. So my very short and brief program in Asia, ASEAN, maybe the 10 countries made just for the brothers and sisters in Africa, Malaysia, Philippines, Laos, Cambodia, Vietnam, Thailand, Indonesia, Myanmar. But Singapore, being the richest, does very beautiful work now by sending oxygen, which is lacking during this pandemic. So there's a lot of networking, a lot of help by the rich to the poor, a lot of educational networking, a lot of exchanges. Even in my question answers, I have been so motivated by your program that I wish to come to Uganda and join your program because it is so beautiful. And this Batwa and this Dr. Birungi, who first started this presentation, I was almost in tears because that's what I love to do. And that's what we do in Asia. So it's time we, Asia and Africa, join hands. So with this, and my apologies again for not showing my face on the camera, I wish you all the best, stay safe, good luck. Thank you very much again for inviting me. God bless.
Yeah, thank you very much, Dr. Prem. I think we are starting to have a global voice. With the trying to deal with this complex problem. So this is the beginning, and I am sure there are all possibilities on how you can actually link up with Dr. Birungi and really work together, since we are really facing similar challenges. I think, yes, I think we have really had insights from at least a significant part of the globe, and thematically, really, we are facing similar challenges. But I will ask just the panelists, and if I would really ask, we don't have to be systematic in this because we have different experiences. But I think Kenneth Yakubu asked a question that to what extent is the plight of indigenous people incorporated in the education of the health workers? I think Dr. Birungi mentioned that the health facilities, their hospital offers training. Though we don't know what proportion of the people training there are actually part of from the indigenous communities. So, dear panelists, if you can briefly highlight any few short answers to this question, that will be helpful, because as long as we really don't think about the issues from the training perspective, we might not be able to solve their problems. So, Dr. Birungi, any insights on that?
Can you repeat the question, please?
The question goes that to what extent is the plight of indigenous people incorporated into the education of health workers? So, Dr. Birungi, can you give us your insights? Then we shall move to Vincent, and just be brief.
Yeah, thank you so much. Yes, effort is made to incorporate their training, actually right from primary education, secondary and tertiary. But of course, there are some of those limitations. I should say that we have been running a nurses training school now for 7 years, and we have only graduated 2 Batwa. Because, you know, there is an element of qualification. You go to school, if you don't score enough to join a health training institution, still you don't go there. But it is a deliberate effort, and one of the graduates is now working in the Batwa settlements. And I had already posted on the chat that the Batwa Development Program, which is in charge of the health insurance, land acquisition, and home building, has now its administrator as one of the Batwa who has been helped through school up to acquiring master's degree in business administration. So effort is there to integrate them. Thank you.
Yeah.
Thank you very much, Dr. Birungi. So, Dr. Vincent, can you give us your insights from Botswana? Or I can repeat the question.
No, it's okay.
Okay,
I
thank
think
you.
it's important. I think it's important for health workers to be sensitive to the state and needs of Indigenous people. And as Dr. Innocent Besige would attest, if we are patient-centered, if we place this patient as the most important person in the consultation between a health worker and a patient, then we have gone a long way to really helping the patients. But again, with the same breath, I think we lose sight of the health of the Indigenous people if we lose sight of the determinants of health, because Dr. Birungi talked about this, land, education, and so on and so forth. So we have to look at this thing holistically, the health of the Indigenous people holistically. And I think the last point which I wanted to make would really be that the health of the Indigenous people, like for instance, TB was almost eradicated, or more, let me say is eradicated in developed countries, not because they developed drugs and anything, but because they have good prevention systems, good houses, good food, good health, and so on and so forth. So yeah, it's a multifaceted thing. We can't just look at health workers and clinics and doctors and nurses.
Yeah, thank you very much, Vincent. Dr. Tijani, any insights from West Africa?
Yes, in Nigeria, for instance, the plight of the indigenous people is wholly integrated into medical education. During the undergraduate medical training, at a certain stage in the clinical training, medical students are made to do rural posting. They are made to understudy these indigenous people, their health needs, and how to address them. It is in the curriculum of all medical schools in the country, under community health posting and sometimes under family medicine rotation. To what extent it is being implemented is another thing entirely, but it is in the curriculum and the applied has been taken care of. It's mandatory for all medical students to do a compulsory rural posting where they learn about these indigenous people, their health needs, and measures to address them. Thank you very much.
Yeah, thank you very much, Dr. Tijani. Dr. Prim, any insights from Asia on how the plight of the indigenous communities is incorporated into the training of health workers? Dr. Prim, are you still with us?
I think he's muted.
No, he's not, but I don't know, maybe it's a connection problem. So, okay, let's move on to our next question as we really come towards the end of this. Again, to you, the panelists. Veronica asked a question that are there awareness of indigenous communities among the general population? I guess the question is if there are any programs to make the plight of these indigenous people, to improve the awareness of the general population about their issues, and how does the rest of the public view these indigenous communities in your respective areas? So maybe we can again start with the Birungi. How do how does the public really view the rest of these indigenous people, and if probably the perception of the public, I don't know, it may be good or not, but are there any any efforts to improve this awareness?
Thank you so much. I think this is a very key aspect, to look at how the indigenous people can be empowered. Because our experience here is that much as the Batwa here hold themselves in high esteem, the general population does not see them that way. And in some way really segregated against because of their low levels of education. They think they understand less. Not many might really feel they can have them even in their homes, to work. I think to me this is a lesson to go with as a take home, to see if there can be systematic approach, to let the general population, know their role that they can actually play to help these indigenous people.
Yeah, thank you very much, Dr. Birungi. Dr. Vincent, any insights from the southern part of Africa?
Yeah, in Botswana, I will put it this way. It is one of the biggest insults is to say a person belongs to those indigenous groups, and even the indigenous groups themselves. Quite a number of them, they really don't want to be identified with their tribes. And there is a lot of assimilation and disguising of their tribes. So this is a reflection of how the general community looks at them. And government itself is trying to correct this and help the indigenous people, but they help them as these unfortunate people, as these uncivilized people who should be civilized. So there is that kind of perspective from the government and even the general population. Only a few activists are talking on behalf of these people.
Yeah, thank you very much. Dr. Tijani, if you are still with us, we would want to hear the insights from the western part of Africa on how the general public perceives these indigenous communities. Yeah, I think Dr. Tijani, is off. Colleagues, we have about 80 minutes to the end of our session. And I think it has been really a great discussion. In a way of trying to really summarizing it and trying to see what are the take-home messages for all of us, we have really all appreciated that the indigenous populations really suffer similar problems, irrespective of where they are in any part of the world. And what is really common to all of them is that they are really poor and marginalized. And as a result of that, they tend to be exploited by the surrounding communities. As you have heard from Botswana, they are the ones which are who look after people's homes and their animals and everything. But specific to what we are really looking at is that there is a lack of access to the health services for various reasons, which are really peculiar to them, because many they live in remote areas, and sometimes access is affected by their cultural beliefs and their ways of living. But what is also clear is that there is a government response everywhere. However, this is really not to the magnitude that it may be required to change their livelihoods. For example, in Uganda here, the Batwa people, it is really the non-government organizations that have tried to step up their plight. So I think we really need to engage the government more to think about these people with their unique challenges. You have heard that the amount of people here were removed from their land when it was regazetted as a gorilla sanctuary. But then no one cared about the resettlement program on how to resettle them and the required social services. And what's also really common to them is that they have poor education, they have poor infrastructure, and there are really no health facilities. And I think we need the infrastructure, we need the road network so that we can have an ambulance system for them. We can have easy transportation so that they actually become a part of the community. And the important thing is that we have all started to think that these are also humans, human beings like all of us. And you have heard our colleague from Malaysia has mentioned that even somebody from the indigenous group is able to, a community is able to win a medal. So I think the onus is on all of us to always really hold them in high esteem and recognize their pride and know that they really require the dignity that all of us deserve, but as well as requiring all of the social services, the health services, education, and everything else that people need to really live a meaningful and dignified life. Thank you very much. A special thanks to all our panelists again for really the various insights. And I think really this was an interesting conversation. I really believe that really toward the end of all of this, we should do a document together with the assistance of Professor Bruce to really look at it and see how well this conversation can be kept alive. Thank you very much for all of the people who posted questions and comments into the chat box and the question and the answer, because it is what kept the conversation alive. I will now really hand over back to Bruce to make concluding remarks and then conclude this webinar. Thank you very much.
Thanks, Innocent. Oh, I've got a bit of feedback there. I do apologise. That's been really inspiring, and to see the dedication of the doctors and particularly Dr. Burungi. Thank you very much for sharing with us what you're doing. I think for those of us that live within communities, live within rural communities, we do get inspired by communities, and hopefully we are able to inspire them as well. And I think the emphasis that all our speakers have put on the need, as Innocence just summarised, around the need for these people to have land, education, the options to be their own health workers, and be involved in the planning. In Australia, our Indigenous communities often say that it's nothing about us without us, and I think getting them involved obviously is a key to some of this. So thanks for the perspectives around Africa. And next week, I've just shared the screen there of the webinar or it's actually the week after next, on Monday the 9th of August. You'll see there that we've got yet another great panel of people from India, Brazil, United States, Canada, Mali, Chile, and Australia. So together with representatives from the Director General's office in WHO, in headquarters, Theodora Swift-Kohler again, and Miriam Massakuitsa, who's from the United Nations Department of Economic and Social Affairs. So we really do look forward to having you join us at that time to continue this conversation, and I'm sure we'll be able to take some really good learnings from tonight's program. The other thing I'd like to just mention is that in the African component, we've got some pretty strong women in the group with Innocent, and they're very enthusiastic to talk about African women and rural health. And that's not for a couple of months now. It's in early October. we'll be having another one of these sessions highlighting African women in rural health and looking at some of those issues before our next WHO webinar. So thanks so much to our colleagues in Uganda. Thanks, Innocent and Jane and Joy. Thanks very much for our speakers tonight, Dr. Burungi, Dr. Tijani, Dr. Seltari, and Dr. Adhesh. It's been just a wonderful night. So thank you all, and thanks to all of you for participating. And we look forward to catching up with you in just a little bit under 2 weeks' time for the WHO series, and in October for the African Women one. So thank you all, and good day, good night, or good morning. Thank you. Bye-bye.
Bye-bye.